Hello, I wanted to review Chapter 1. I know we went over it in class today, but I want to kind of hit on some parts that I feel are going to be very important. So, first chapter is preliminary steps in radiography. Ethics. I said we would touch more upon this, and it's defined as a profession's moral responsibility and the science of appropriate conduct towards others. The ASRT developed a current code of ethics for the United States. So here I have a published code of ethics. It says ART, AART, and ASRT in this case are synonymous. So I do have a PDF that's available to you because this isn't as clear. But there are 10 codes of ethics I think that we need to touch upon. I think it's very important in our line of work. So the first thing is that number one, the rad tech acts in a professional manner, responds to patient needs, and supports colleagues and associates in providing quality patient care. The rad tech acts to advance the principal objective of the profession to provide services to humanity with full respect for the dignity of mankind. Number three, the rad tech delivers patient care and service unrestricted by the concerns of personal attributes or the nature of the disease or illness, and without discrimination on the basis of sex, race, creed, religion, or socioeconomic status. Number four, the rad tech practices technology founded upon theoretical knowledge and concepts, uses equipment and accessories consistent with the purposes for which they were designed, and employs procedures and techniques appropriately. Number five, the rad tech assesses situations, exercises care, discretion, and judgment, assumes responsibility for professional decisions, and acts in the best interest of the patient. Number six, the rad tech acts as an agent through observation and communication to obtain pertinent information for the physician to aid in the diagnosis and treatment of the patient, and recognizes that interpretation and diagnosis are outside the scope of practice for the profession. So I know we touched upon that during the lecture, that you are not to give any diagnosis to the patient. That is out of our scope of practice. Number seven, the rad tech uses equipment and accessories, employs techniques and procedures, performs services in accordance with the accepted standard of practice, and demonstrates expertise in minimizing radiation exposure to the patient, self, and other members of the healthcare team. The rad tech practices ethical conduct appropriate to the profession and protects a patient's rights to quality radiologic technology care. Number nine, the rad tech respects confidences entrusted in the course of professional practice, respects the patient's right to privacy, and reviews confidential information only as required by law or to protect the welfare of the individual or the community. The rad tech continually strives to improve knowledge and skills by participating in continuing education and professional activities, sharing knowledge with colleagues, and investigating new aspects of professional practice. So in our line of work, we do have continuing education, and that's the way that we are able to stay on top of advancements in our profession. So cassettes, we went over this in class, cassettes with films of four types. Film is still used in rare occasions. Some of the smaller clinics out there do use film. Then the IP, which we took images with, has a storage, the phosphor plate image, solid state digital detectors, portable digital radiography, and fluoroscopic image receptor. So you can see the cassette with the film. PSP image plate, what we use today in lab. Solid state digital detector has it built in our chest, in our upright chest unit. The tethered DR, still used in some locations for portables. The wireless DR, And we touched upon fluoro. We're not going to get too much into fluoro at this time. So we went over this in class, the superimposition, adjacent structures, optical densities, contrast resolution, spatial resolution, magnification, and shape distortion. So digital radiography is the brightness displayed image primarily controlled by rescaling. And we showed that in lab today, how you can window and level the image. Screen film radiography optical density is the overall blackening of the film, and that is controlled by your MA, your exposure time in second, and the milliamperes second. So MA times time is your mass, and that controls your optical density brightness. And here you can see the different densities. And as I wanted to repeat, that KV is very important for the DR, so it's better to, if you always want optimum, but if you're going to err on the side of being a little bit darker, because that way you can control the brightness. If you are underexposed, you can't really window and level that, so you're going to probably have to repeat. So like I said, err on the side of excess if you're going to. Always try for the optimum. And the contrast comparisons, if something has too much contrast, and this is ideal here. And it used to be called recorded detail, then that's the ability to visualize small structures, and it's controlled by the IP phosphor, the digital size, del size, geometry, distance, the focal spot size, motion, which we discussed, film, and an intensifying screen. That's spatial resolution. And distortion, shape distortion is elongating or foreshortening, and that's controlled by the alignment, the central ray angle, the atomic part, the image receptor, and angulation. Then magnification is size distortion. We talked about that. Object image, so that's from your central ray to your part, and then your source image is from your central ray going to your SID, to your receptor, your IP receptor. And we went over anatomical position. It's facing forward with the hands, with the palms outward. And we went over some of these things already, so I won't want to repeat some of these. Just make sure that you stock your room. Make sure you linen, contrast. Not only that it's stocked, but that make sure you look at the date, make sure it's not expired, or if it's close to being expired, let the technologist know. Keeping the equipment clean, wiping everything down. Hand washing, can't state enough. Hand wash between patients, even if you're wearing gloves. That's the best way to control the spread of microorganisms. Protect, so wearing gloves, gowns when appropriate, and wearing a mask if the patient isn't wearing a mask and has any types of coughing, anything like that. And we went over motion, how it could ruin your images, and involuntary, voluntary, and the equipment. And we went over the involuntary motion. Lack of voluntary motion is caused by nervousness, discomfort, excitability, mental illness, fear, age, breathing. So the things that we can't control are the breathing. And you can control image voluntary, give patient clear instructions, providing patient comfort, adjusting support devices, applying immobilization, and decreasing your exposure time. Image ID, So wanted to just state how important it is. I know we went into some detail about patient identification, patient's birth date, the name, ID, if they have a wristband, just to verify. Markers, we went over markers, how important they are to use your markers with your initials on there. And like I said, when I do come out to clinic, if you're showing me an image to be comped on, that your marker has to be on there with your initials. And if there's another technologist marker alongside yours, that's fine. And we already went over the quizzes, so no need to go over there. And then the 3 general IR positions, longitudinal, horizontal, corner to corner. We went over that. It's like if you're doing a tib fib, you're using corner to corner, so you try to get both joint spaces, the knee joint and the ankle joint, on one film. If you're not able to, then you need to use take 2 different images. Make sure that you do include both joints. We talked about the central ray. Central ray is centered to the IR. And we talked about angling the CR through the ports of interest. The source image distance. And we talked about 40 inches, 48 inches, and 72 inches. And that's controlling magnification, spatial resolution, and patient dose. And this is what we went over, the 40 inches, 48, and 72 inches. And it's, like I said, it's used on mag examinations to increase OID to reduce magnification. Restriction of the extra beam to only the anatomy of interest. It serves 2 purposes: minimizes patient exposure and reduces scatter radiation, collimation. We talked about radiation protection. Each center will have their ideal range, age range. It could range some places from basically newborns up until 60 years old. So there's some instances that you may not be able to shield, but any time that you can shield, we recommend that shielding. If it's a clinical objective is not compromised, so you don't want to put the shield, the lead shield in the area of interest, because you won't be saving anything, because you'll have to repeat the x-ray if you do cover an area that needs to be visualized. Introduction to digital imaging, we can touch on this. So they use a different IR and image display from analog, which is a screen. In computer radiography, the IR is an imaging plate composed of a phosphor plate. And so I was telling you about that you do need to run that. Then after exposure, the IP is read by the digital reader, the computer, and the image is displayed on the monitor. DR uses solid state. Attention to detail is key to quality digital imaging, and optimum KV is not essential to quality, not as much as it is so slightly higher KVP yields better image than slightly lower. So that goes back to where I was saying that DR uses higher KVP than film. The IP phosphors are hypersensitive, so if you split the cassette, technique is used. The exposed side must be protected. We don't use that too much anymore. Normally we just use 2 IP. We take 2 images on 2 separate IPs. And so overexposure or underexposure is not determined by the display image. You'll have something that's called the exposure index, and you'll learn that further as you advance the exposure numbers. It's to be within a range. That determines whether the image is with quality range. You can't always tell just by looking at the image if it's under or overexposed. You have to look at the IR, or they call them different things, exposure index, and that's a range that the image needs to be in. Use collimation with care. IPs are not light tight, so short exposures to light does not ruin the image quality. IR phosphors are more sensitive to scatter radiation. Some examinations require GRUD when using digital that did not require GRUD with film screen. That could be when you're doing a portable chest x-ray. Technique charts, they're supposed to be posted in every room and on the portables. That tells you by patient size, patient thickness, and body parts what the ideal technique should be. Primary factors to the introduction to exposure techniques. Primary factors are mass, KVP, which we touched upon, mass, the automatic exposure control, SID, patient part thickness, grid, the CR exposure indicators or other digital exposure value estimates, IR or collimated field dimensions, screen film speed number, and electrical supply. Let me touch upon automatic exposure control, also known as photo time. They call it AEC, and it's also used. It's also called photo time. You'll hear those terms interchanged. Certain pathological conditions require a decrease in technique. If the patient's elderly, if the patient has, when doing a chest x-ray, if they have a pneumothorax, emphysema, emaciation, degenerative arthritis, atrophy. So these conditions will, you will either increase or decrease your techniques accordingly. Certain pathological conditions require an increase in technique. If the patient has pneumonia, pleural effusion, having fluid in the lungs, hydrocephalus, enlarged heart, edema, ascites. So any of these, you would need to increase your technique. Technique, except pathology type. That doesn't, the charts do not include pathology type. Pre-exposure instruction, very important to give patients clear instructions to try to obtain the most optimal images. Many projections require patients to suspend respiration at full inspiration or expiration, and we talked about that today. Full inspiration for chest generally. Sometimes you do an inspiration and expiration chest, and also for abdomen. You want to make sure generally done on expiration or just holding your breath. The tech should instruct patients on the required breathing before making the exposure, explain so the patient does understand. If they're taking a deep breath, blow it out, to hold it out, or to take in a deep breath in and hold it. You must be clear on your instructions. Won't touch too much about this, but obesity has doubled within the last 15 years. Obesity is defined as an increase in body weight by an excessive accumulation of fat, and this is what the BMI, body mass index, would categorize obesity. So getting towards the end, communication is the biggest key to all imaging procedures. Try to be very empathetic when you communicate with the patient. Make sure they understand. I know language could be difficult, so if you have somebody that can interpret, avoid mentioning weights. Just try to be as kind as possible. Explain the personnel required to safely move and/or transfer. Make sure the patient can support the patient's weight, and all tables should have indicated on there what the patient's weight is. Generally, it's around 350 pounds. Some hold up to 500 to 600 pounds. Communicate each part of the transfer process to the patient. Explain position required for imaging procedures, and provide support and assistance to maximize patient comfort and security. And we talked about palpable landmarks, and we talked about the symphysis pubis, and I want to just emphasize that we shouldn't ever have to touch the symphysis pubis. There's landmarks that we do use. We talked about using the crest, the ASIS as landmarks that you should be able to use to palpate, to do any abdomen, sacrum, coccyx, anything like that. So that's the conclusion for our first RT 1113. So if you have any questions, I want you to be comfortable in calling me or talk to me after class or during class if you have any questions. Thank you.